where I will show another video. Yeah, it's coming. Okay. There will be some change with the program. We will start in 5 minutes. Unfortunately, because of that coronavirus issue, the program became messy, and we were supposed to talk on Vst pulmonary atresia MAPCAs, but Dr. Talvar is not aware of that talk. I had another video that was originally scheduled for the first day of the program by Dr. Pizarro. He just sent it last night. Maybe we could use that video to fill up that space. It's a supravalvular aortic stenosis repair, a modified Brom technique. And this video was sent by Dr. Pizarro. Let's go and... Can you? Oh, okay. He's bringing something else. Okay. Let's wait. It's coming now, looks like. Okay, thank you. Supravalvular aortic stenosis is a rare abnormality. This is a baby that was operated by Dr. Pizarro. You see the severe gradient of 90 millimeter on the supravalvular aortic area. There are different techniques of operation, including pantolon patch, Brom operation, 3 patches. And in this operation, he used a modified Brom technique. May I have a pointer? Dissecting the aorta. Which way is it? I need a pointer. Dissecting the aorta completely is important, and then transecting the aorta at the narrowest side of the stenosis it is important to be very careful during this stage. Sometimes there are a lot of fibrous tissue, and that coronary orifices are very close to this area, and it might be dangerous, and be very careful. Now he is extending an incision towards the left coronary sinus, and now opening the right coronary sinus just above a few millimeters down to the valve. And again, most important issue at this point is not to damage the coronary arteries. This is a pretty much good anatomy here, but most of the time you see a difficult and very thickened and dysplastic aortic valve, and the coronary orifices are also very small, and the myocardial protection is a significant problem. Here's the left coronary artery, and resecting the piece of dysplastic aortic valve. You see now the proximal aorta has 3 opening, and another counter incision on the distal part of the aorta, so he could use that distal aorta as a patch. It's again very important for this kind of operation to cannulate distally as possible, and then completely dissect and free the aorta, so you could have a tension-free anastomosis. Now we have opened proximal part with 3 slits, and then the counter incisions on the distal ascending aorta, and bringing them together and starting starting the suture line on the left side, lowest corner of the left coronary orifice. And again, beware of the coronary artery orifices. That's I tell you that this looks like a very good anatomy, and most of the time with that supravalvular aortic stenosis, that coronary orifices are very small and very dysplastic. You don't even have enough tissue around there. Again, this anastomosis should be perfect and should not rotate or kink the coronary orifices. Otherwise, you will end up myocardial ischemia, which might be impossible to treat without redoing the anastomosis. Here is the left anastomosis. Left sinus anastomosis is completed. Now the right coronary sinus anastomosis, bringing that tongue of the distal aorta to the incision on the right sinus. One thing I recommend over many years of surgery, whenever I have a supravalvular aortic stenosis patient, I stay in the operating room from the beginning of induction of anesthesia. They are sometimes very tricky patients, and during the induction, they can go easily to ventricular fibrillation due to myocardial ischemia. And I personally stay in the operating room from the very beginning of the operation. I strongly recommend, and it's not uncommon to have myocardial problems during the induction for these patients. And another tricky thing is also the myocardial protections, since that coronary orifices might be very narrow. Then now doing the anastomosis of the non-coronary sinus. You see, he's using this fibrous tissue as reinforcement for his anastomosis, which is very helpful. And the completion of the anastomosis anteriorly, this is now becoming the end of the operation. Here's the reconstruction completed. You see there's a wide aortic anastomosis, and echocardiogram shows no flow obstruction and good laminar flow on the ascending aorta with no gradient. Again, this video is sent by Dr. Pizarro, and we fill a space. Any questions, I would be more than happy to answer on his behalf.
So that was a very nice video. See, as we all know that the length of the aorta, which is affected because supraorbital race can be a very long length, sometimes going up to the base of the innominate. And that probably creates a problem in trying to get an end-to-end anastomosis.
Yeah, this is a very favorable anatomy. This is one of the most favored anatomy I ever seen. Most of the time it's longer, and then the very dysplastic aorta, it might be very difficult to do such an operation.
Even giving quadriplegia becomes hell because the coronary osteoid get involved.
Yeah.
Now my question to you is, like, it does not seem like the classical Brom repair. Because
no, it's a modified one.
Yeah, because in the Brom repair, the V which you excise is filled with the pericardium.
Yeah.
Treated pericardium.
As his title, it's modified Brom.
Yeah. Because as far as whatever I understand, whatever I've done is fill up those sinus with pericardium. Yeah. So you avoid the coronary distortion, and you get, especially the distal aorta is big, you get a lot of length and width of the aorta too. Anyway, the video is very nice. So what is your take on the other methods of repair, like the Magoon repair or the Doty's repair? One repair is when you augment the anterior two sinuses, like you put a pantaloon-shaped patch.
I most of the time like modify Brom technique, and if possible, and use a pericardial.
This is the ideal technique.
Yeah.
But sometimes when this is extensive, then you're better off just doing the two-patch sinuses. And sometimes, rarely, if the patient is very high risk, you just augment one sinus.
Okay. Sunji, do you have anything to present?
You also didn't come to know that this is Aorterosus.
You are presenting double switch operation. Yeah. Do you want to go it now? Yeah. Use your own computer or? Okay. Then I will leave this here. Then continue after you. Dr. Sano will be presenting double switch operation in corrected transposition. This is again one of the most controversial issues in congenital heart surgery, especially timing and performing this operation.
Okay, the natural history of congenital corrected TGA is not as bad as we thought. we think that some patients live into the 5th or 8th decade, but uncommon. The systemic LV is not sole problem. Associated region, especially a systemic AV valve regurgitation, lead to LV dysfunctions. So in the ACC/AHA guidelines, that in most cases this ventricular dysfunction appears to be related to systemic AV valve regurgitation, and if the absence of associated congenital anomalies, especially the systemic AV valve regurgitation, the primary systemic ventricular failure is uncommon. The associated anomalies, as you know, that the abnormality of the systemic AV valve is almost 90% of the patient, and it's typically like an Eberstein-like malformations. And the VSD is 70% of the patient, usually perimembranous, and pulmonary stenosis in 40% of the patient. This is just one example of the congenitally corrected TGA, and this patient is my oldest patient, 58 years old. And she was diagnosed as a corrected TGA, but initially very mild Truncus regurgitation, and just a follow-up without any surgical treatment. And then at the age of 33, she found a palpitation arrhythmia occasionally, and this one is becoming worse. And then she had the severe RV failure, and with the systemic AV valve regurgitation is getting worse. So at the age of 57 years, she had a catheter study, and the diagnosis was the same, severe Truncus regurgitation with congenital corrected TGA. So I was asked from other university in Tokyo what to do, and I said that because of her failure, it's just only the systemic AV valve regurgitation. It's not RV failure. Also, there's no option of transplant in Japan. So I talked to them that if I do operate, I do just replace the Truncus valve. And then this is just my option. But they said, oh, you were the only one surgeon who offered the surgical opinion on a decision on offer. And she was referred to Okayama. It takes like 3 hours by bullet train. And then we have surgery, and then replace the valve with SGM31. And then the pacemaker, just the lead implant in case of complete heart block. And she was back to Tokyo by herself. So after Truncus regurgitation, she was in the hospital for more than 1 year. And after replacement, she was back home. So this is a little bit like a different experience, but usually the surgical option of a corrected TGA is physiological repair, so-called classical operation, or the anatomical repair, the double switch. The so-called true double switch is sending or the mustard plus atrial switch operation, but also especially in Asian countries, there's lots of the patient had the VSD pulmonary stenosis, so the sending or mustard plus lasterity type operation, 1.5 ventricular repair, or the univentricular repair, or just the further palliative procedures. These are the options. And always debate is anatomical repair better than the physiological repair. This is the paper from Munich. The long-term result of arterial switch operation and TGA is much better than saline or mustard. These are another papers. The mortality or heart transplant of a double switch operation or the corrected TGA is early mortality and late mortality, and including these two, just over 20% or a little bit more. The heart transplant mortality is probably a little bit better, but it's not. That is only the like 5 or 10 years. This is the paper published from Tokyo Women's. Ima was there. They have lots of patients. And then a long-term follow-up data. The one group is conventional, like a medical treatment, and also the conventional repair. And then the conventional Artery and double switch, usually like a saline or the mustard plus arterial switch operation, and the other one is with the Artery, and then the Fontan. The long-term 20 or 30 years follow-up data showed all these groups have not much difference. But if you carefully look at these one, if you do double switch, the most of the deaths occurred soon after the operate, because the operation is quite complex, and technically it is not easy to do and take a long time. So these days, it's more than 20 years before. These times, the mortality after double switch operation in most of the centers are very high, but now probably different. And once the double switch operation is successful, then the late death is much less compared to the classical or conventional repair. They said that the patient with the tricuspid regurgitation in here is much worse than the no tricuspid regurgitation. So that shows that the indication, a definite indication of double switch should be the Alfrey morphology in the systemic ventricle plus the moderate to severe AV regurgitation. This is another paper from Great Ormond Street. They concluded that short and intermediate morbidity and the mortality were greater in patients undergoing biventricular repair than pulmonary connection. But it is unknown whether the long-term result of the Fontan better than to ventricular repair. So this is this paper is published in 1996. So not many people know that like 20, 30 years after the Fontan, and we know that lots of Fontan patients have a problem in long term. So if it's possible, the better to do the biventricular repair. This is also from the Boston children's the published data. That's also the 1996 until 1996. They said the Fontan best outcome is a Fontan. The worst outcome is a patient requiring tricuspid regurgitation at initial operation. So these are a little bit old data. Okay. If the patient have a corrected TGA with associated anomalies such as the tricuspid regurgitation, what are the options? That's always a balance. The Fontan is an easy way to do. Maybe like the bilateral grain and the Fontan, that's all. The double switch, on the other hand, is a very technically demanding operation, take a long time, but the long-term result should be much better. So it's always a balance, which one is better. The causes of LV dysfunction are systemic. LV dysfunction after double switch is the systemic ventricle, which cannot be adapted to systemic circulation, such as simple corrected TGA. If you do, we need to do like a bilateral banding to train them, but not always these ventricle be tolerated with the banding, and then the left systemic left ventricle function and the thickness is improves. The AV incompetence, the coronary ischemia, and the arrhythmia is a problem, and the also in TGA, corrected TGA, VSD pulmonary stenosis, the long LV outflow tract tunnel in lacery type operation may have a problem. This is the paper from François Lacouguiers. The patient undergoing a lacery type operation often require long intraventricular rerouting patch. It may be a risk factor for the mortality, the left ventricular outflow tract obstruction, and impaired left ventricular function. So this one is a schema of the long interventricular tunnel. This area is a functional LV. This area is a non-functional left ventricle. So if this one is long, and then the cavity of this area is huge, then non-functioning LV should function much more to cover these non-functioning areas. That's why the long-term result is no good. So how to solve this problem? Probably the option is either to do Nikaido or double root translocation and a half-turn truncal switch or the pulmonary translocation, and to reduce the size of the non-functioning LV. Like here, the non-functioning LV is much smaller. These are probably the much better long-term result. So we analyze our data and then published the 43 patients with the corrected TGA or TGA VSD or complex DORV, who need the long interventricular tunnel. We lost one, and the late death 3. So this is the patient. Here, this one is quite far away from LV to aorta, so they need a long interventricular tunnel. So we divided in two groups. The length between the interventricular septum, top of the ventricular septum, and the aortic valve. Length is less than 80% of normal LVDD, and group B is more than 80% of normal LVDD. This one is a long interventricular tunnel group. And this one very clearly showed the patient with the long one. The longs is the short one is 53. The long one is almost double. And then the result is in the short interventricular tunnel group, the 34 patient, no death, no early death, no late death. And then group B with the long interventricular tunnel group have 1 early death and 3 late deaths. It very clearly showed that the risk factor of the double switch in this group is the long interventricular tunnel. And, it's also very much clear. It's no death at all, and 16 years follow-up. And then long interventricular tunnel have a couple of patients died due to the arrhythmia in long term. So this one is here is we call it short. This one is quite long. Here, very long interventricular tunnel. So the only if we just focus on corrected TGA in 38 patients, it's probably the same result. And also this one and ascending artery is 11, and the ascending arterial switch is 8. And these, all these three are along interventricular tunnel. The ascending and the 4 patients have 1.5 ventricular repair. So the anatomical double switch, or the including double switch and the 1.5 repair, the so-called anatomical repair is 25 patients out of 38. The non-anatomical repair in the 13 patients, the conventional repair 2, because of the VSD was quite small, restrictive, and also the other one was our experience. We just before we started, routinely started double switch, but the patient died because of the heart failure. The 11 patients have a fontan, and these were most of these were the long interventricular tunnel. So we changed the policy. If the patient need a long interventricular tunnel, we do not do a double switch unless the patient is a good candidate of double root or pulmonary translocation. So this one is the indication non-anatomical repair is the patient with adult. We think the more than 20 years of age is not a good candidate of the banding and the LV training, and also the difficulty of interventricular rerouting in the small VSD and the long distance, the straddling AV valve, and hypoplastic RV or LV. And then the 11 patients needed the LV training for corrected TGA without VSD. The patient from 9 months to 16, our oldest patient is 16 years old. The patient have a double switch setting in 11, and then double switch with half setting, and the bilateral grain in 2, no mortality. These were the patient and the long-term result. Most of these patients have a very good condition with a low VNP, and these patients are not very good. This patient have developed like a complete heart block, and also this patient, also one of the 3 patients who did like a double switch in teenage. So this is the example of the LV training and the patient and 13 years old, the corrected TGA, and then referred to as 7 years, the LV morphological LV pressure was 33, so the LV pressure ratio 0.32, and the patient had a moderate tracus regurgitation. So we plan to do an LV training. So this patient had the fast bending, but couldn't do a tight bend. The patient couldn't tolerate with a tight bending. So we did the band, a little bit loose band, and then in a couple of years' time, we did the second pulmonary banding, and then make the banding tight, and then the LV-RV pressure ratio increased, so we did a double switch. The other patient is 11-year-old girl. This patient had the severe tracus regurgitation and heart failure, and referred to us from another unit at 3 years of age. LV-RV pressure ratio was 0.26. We plan to do training and do double switch. There's no option other than double switch. So this patient also the banding the first time, and then it took 6 years, and we did a second banding, and then the double switch. But this patient, a long-term result or is not as good as others. This patient is the 16 years old. The LV pressure ratio was 0.28. So we did the first banding at the age of 11, and then the second band in 2 years' time, and then wait another 2 years, and we did the double switch. So these are the course of three teenage patients. The patient's okay, but it's two of the three teenage. The ejection fraction is not as good as RE double switch group. So we recommend to do double switch before teenage. The clinical course also the same. These patients, the teenage group is not as good as the double switch in the younger age. The freedom from reoperation is of course, the best is a TCPC. If we do a double switch, especially the lastly, most of the patients need a reoperation because the RV outflow tract obstruction. The one of the option is also especially in the patient with dextrocardia, the usual thinning operation to me is not easy to do. So I prefer to do a half thinning and add the bilateral grain. And also some of the patient with the long interventing tunnel, the pulmonary root translocation, and the double root. This is the patient who we did pulmonary translocation. Before the pulmonary translocation, the interventricular septum to aorta was 22. And after the pulmonary translocation, taking out the pulmonary valve annulus, then this one shifted to here, this side, the length becomes shorter. That's only 1 year after, so now the little bit more closer, shorter, and 16 or 15. So now our paradigm of managing patient-corrected TGA is our first choice is double switch. If the patient interventricular septum and the LV aortic valve length is long, more than 80% of normal LVDD, we prefer to do TCPC. And if the length is shorter, a double switch. If the patient is without a VSD or the received VSD, we do a banding to train the LV. With some of the patients, especially more than teenage or more than 20 years, these patients quite often does not respond to the banding. So then we do a TCPC. In conclusion, the anatomical repair should be the first-line strategy for surgical correction of corrected TGA in our unit. The LV training should be done early in life, if possible, within like 1 or 2 years of age. The further effort to reduce the risk of post-operative left ventricular dysfunction after anatomical repair is required, and the interventricular septum, the aortic valve length should be taken into consideration when selecting the Artery type double switch operation. And additional bilateral gland or use of in situ aortic pericardial patch may be improved short-term outcome double switch operation, especially like a dextrocardia. Thank you very much.
Sunji, thank you. This is a very difficult and one of the most controversial issues, and LV training. That is my experience as well. You know, I had never had a patient. Actually, this was a very sad story. The last one, I did LV training, although we have pretty much good response. This was a 18-year-old girl, but you know, it ended up with a disaster, and since that time I stopped doing any patient older than like 6-8 years for LV training. It's not what is your latest age? You know, you have this now 10. What is the most optional age to train the latest time?
The latest time, it's a quite difficult question. Preferably, ideally, within 1 or 2 years. Sometimes 5 or 6 years, probably okay. And more than 10 years, it's very questionable.
Very exhaustive presentation, Dr. Sanu. There are a lot of debate, as you said, about the management of these patients. If you read the papers from Chicago group, they talk about the physiologic repair. Like you close the VSD, leave some element of the obstruction to the LV to PA side, and then do a gland. So they have documented very good results with that strategy. The opposite to that would be the reports from the Jonas group, in which if the LV is regressed, the patient is saturating all right, then use the pulmonary artery band as the final therapy and don't do anything else. So they have also documented very good results. Because the problem in the corrected TGA which we have observed is that the sending component is one of the most difficult things to manage, because they have heterotaxy. Often the pulmonary venous chamber is placed behind the heart. The volume of the atrium is less. So the sending components become very difficult. So Frank Henley group has, they just try to, they do a gland on the top and they just do the route the IVC return towards the mitral valve. So it's a very complex subgroup of patients. We have also published our experience with the double switch operation, and that was in 2009, and something like 78 patients. And we found that the rates of reoperation were very high in the group which had sending and diastole, because the conduit was requiring a change. But strangely, in those patients in whom we were doing the traditional double switch for arterial switch plus atrial switch, they had a very high incidence of left ventricular dysfunction post-op. And if you read the data from the Bill Brown group, that was also quite similar in these patients. So I think the management of double switch is, this condition is still evolving. We also presented a paper, I think 2 years back, in which we compared the result of the Fontaine operation with the double switch, and we found that the Fontaine seems to work equally well, because these patients have got two ventricles instead of one ventricle. So the failure of both the ventricles is not very common, and it avoids the complications of the heart block and baffle obstruction and the superior vena cava syndrome, which you can get with the double switch. So I think the final word is yet to be said, and a lot of people are using different methods of. And as you said, like, we do not like to intervene in any patients more than 7 or 8 years of age. We have patients in India who are 25, 30, and they've gone on till that time. And then the only problem is the tricuspid regurgitation. And if you just close the tricuspid valve, it is good. Sometimes the PA band occurs very good in the presence of the TR, because then once you add a PA band, it shifts the septum to the opposite side, and it leads to a reduction of the Lv dysfunction and the reduction of the TR if you do a pulmonary artery band. So that is also we have been using. Just do a PA band, make the septum alignment different, and then reduce the TR. And these patients may then not require anything. So thank you very much.
Yeah, that's an issue with the protective PA band. That patients do so well on long term that you don't want to go ahead and do a double switch operation. Yeah. Most of the time they do very well with the PA band, and then we have the natural history of the long term ccTGA with PS coming to the very old ages, and it's a dilemma there. At that point, you plan something protective band and then plan for a long-term double switch operation, and the patients are doing well, and then the decision is something very difficult, exposing patient to a major operation.
It is destination therapy for these patients.
Yeah, we have in the UCSF, we was offered the surgical surgery, and I think nearly like late 40 or 50 years old with corrected TGA. The tricuspid regurgitation is getting worse and worse. We said the cardiology, one of the options is a banding, pulmonary band, because if you see the geometry of the interventricular septum, this was shifted. The tricuspid valve was not like a dysplastic. Only the problem is the interventricular septum, like a geometry. So one of the options is much less invasive treatment. Might be the pulmonary banding to shift the ventricular septum. The tricuspid regurgitation is more than moderate, severe, and maybe less than moderate. So the patient. The clinical condition may improve.
Actually, the degree to which you should tighten the band is also a difficult proposition. So what we have been doing is we put a transesophageal echocardiography probe. Then as you do the banding, you see how the septum shifts to the other side. And you can actually see the reduction on the TR immediately on the table. So that when to stop is when the TR reduces, but important thing is there should be no mitral regurgitation. If you are doing the banding and your mitral regurgitation appears, that is the time you should stop. And second thing which we do is we place a central line in the right atrium and measure the baseline pressure in the right atrium. So when you are banding, and if the CVP, central venous pressure, changes more than 2, or if there is appearance of the mitral regurgitation, that is, I think, the time to stop. And you can then leave these patients alone for a long time, and they will do well.
Thank you, Sanjay. I think Dr. Sakamoto is not here, and then myself will be presenting Truncus arteriosus with interrupted aortic arch. I have nothing to disclose, and as we all know, interrupted aortic arch is a very rare congenital heart disease, and it's less than 1% of all congenital abnormalities, and it is characterized by lack of continuity between ascending aorta and descending aorta. It is associated with major intracardiac lesions, including VSD, Truncus arteriosus, TGA, and aortopulmonary window, and less than 15% of the cases with interrupted aortic arch is associated with, less than 15% of the cases with Truncus arteriosus is associated with interrupted aortic arch, and Truncus again is a uncommon cardiac anomaly. It is less than 1% of the all congenital heart diseases, and 15% of these kids again has kind of Truncus arteriosus. This paper from Congenital Heart Surgeon Society study reporting 50 neonates with Truncus arteriosus associated with interrupted aortic arch, and overall survival is 44, 39, and 31% at 6 months, 1 year, and 10 years. This is a really very deadly combination. And repair associated with Truncus arteriosus remains a difficult surgical challenge, although the results improved over the last 10 years. However, the rate of development of residual lesions such as truncal valve regurgitation, bronchial compression, and stenosis at the site of the anastomosis remains very high. This study from Congenital Heart Surgeons Society analyzes the mortality and reinterventions in 472 neonates with interrupted aortic arch and low birth weight immediate presentation type B interrupted arch and major associated anomalies including Truncus arteriosus has highest mortality, and the highest mortality in patients with common arterial trunk undergoing interrupted aortic arch repair is the group with the truncal valve surgery. This is another Thoracic Society of Thoracic Surgeons Congenital Heart Surgery database study. The mortality is around 60% with any patient with common arterial trunk undergoing interrupted aortic arch repair and truncal valve surgery combined. This study, again, the same study, 572 patients, and here, any reoperation valve repair did not survive, reoperation valve replacement did not survive, reoperations for valve replacement did not survive. This report from Melbourne Group Royal Children's Hospital reports their experience with Truncus associated with interrupted aortic arch. There were 16 patients. They have 2 early deaths with 12.5% mortality, and 13 patients with long-term follow-up of 18.2 years, and 4 had aortic reoperations. 1 required truncal valve replacement, 1 required LVOT, and 5 required RVPA conduit replacement, which gives like 5, 6, 7, 11, or more than 80% of the surviving patients required kind of reoperation or reintervention. And early physiology, no effects on the fetal circulation. However, there are reports that adverse effects of cognitive development, and then PGE revolutionized the treatment of interrupted aortic arch. Diagnosis is mostly by echo enough, and sometimes you might need to use MRI or CTA to evaluate the length of this continuity. And it's echo more than 95% of the cases is the best technique, and it gives you all the data you need. And surgical goals are separation of systemic and pulmonary circulations completely, unobstructed aortic arch continuity, a competent truncal valve, closure of septal defects, and provide unobstructed pulmonary blood flow. Preoperative decision making depends on the type of repair, complete versus palliative. To be honest, at this current era, I don't think there's any role for palliation for this kind of anomaly, and a complete one-stage repair is the best approach. And aortic arch repair could be done either with a direct anastomosis or using a patch to reduce tension. And here, the decision is either to go with the total circulatory arrest and low-flow cardiopulmonary bypass. It is completely depends. It completely depends on the institutional protocols and preference of surgeons. I personally always do it on total circulatory arrest. It just less than 20 minutes of total circulatory arrest is enough for this kind of procedure. Approach to VSD is important. As you know, this patient has a very hypoplastic coronal septum, and approach is most of the time from transpulmonary area. RVOT reconstruction is the choice of the conduits that might be used, and if patients will need a truncal valve repair or not. Again, truncal valve repair is a significant risk factor for these patients. And here is one of my patients, and technically appropriate monitoring is very important. Right radial and umbilical arterial monitoring, median sternotomy, and you have to completely dissect and mobilize the aorta and pulmonary arteries, and sometimes abnormal right subclavian artery or left subclavian artery might need to be ligated. Cardiopulmonary bypass is double cannulation, ascending ductal cannulation. What is most important here is the accurate arterial cannulation site. It should come to the right lateral aspect of the opposite to the location of arch anastomosis. I don't go high or left lateral, and it should be on the right side to provide you a good anastomosis. Here is the patient under total circulatory arrest, and PDA is resected. Since you have a truncus and you have enough tissue to use for reconstruction, and here are detaching the pulmonary arteries, left and right PAs. Here is the truncal valve. It's important to completely dissect for tension-free and kink-free anastomosis on a later stage. Exposing the truncal valve here. Luckily, this patient has no truncal valve regurgitation. Here's the coronary orifice. Okay, move some. It's important to give cardioplegia directly to the coronary ostia. I use Del Nido cardioplegia, and most of the time I go with around 50 minutes of cardioplegia time without giving any additional cardioplegia. And since anyway these patients are cold, Arch anastomosis is important, and a critical point here is the distal end of the ascending aortotomy. And to have a widespread anastomosis, it should be close to the bifurcation of the aorta and into the innominate and left common carotid artery. And you can again do the arch anastomosis completely on the ascending aorta. You can do it as a direct anastomosis. In this truncus patient, we have enough tissue, and this will be a direct anastomosis without tension on the anastomotic side. However, you can also use a piece of pericardium to, here's this one now, going that. Or you can use a piece of pericardium to reduce the tension and reduce the incidence of restenosis and bronchial compression. Vst Closure, again, coronal septum is markedly hypoplasic and a transverse pulmonary arteriotomy for any of these cases. And since this was a Truncus patient here, going through the right ventriculotomy, closing. Closing the VSD with a dacron patch on continuous suture. And you have a very nice exposure here without any problem through this approach. And then homograft to provide the continuity, and this is the end of operation. Between 2002 and 2017, I have 12 patients with truncus and interrupted aortic arch. Average age 5.2 years old, average weight 3.6 kilogram, 11 head, type B interruption, and types of the truncus listed below. If Dr. Anderson would be here, he would kill me now saying that this kind of classification. And 8 patients had reoperation, and we had 1 mortality. This was the patient with truncal regurgitation who underwent truncal valve repair, and we have median follow-up of 5 years, and very importantly, this patient had significant reoperations. Most of the RV and PA conduit. 2 patients required branch PA stenting. 1 patient with contegra had endocarditis, and 1 patient needed bronchial stenting, and 1 truncal re-repair, and this is the mortality patient. The repair remains a difficult surgical challenge. However, results have significantly over the past few decades, and one-stage repair is the procedures of choice, and development of residual lesions and requirement for reoperations should be kept in mind. Reoperation reintervention is very high, and this patient should be followed closely. Thank you very much. Any questions?
That's a very nice presentation. I saw you cannulating the middle of the ascending aorta.
Middle?
I saw your cannulation that was in the middle of the ascending aorta.
That was it was not the truncus patient.
Okay.
But for interruption, most of the time on the right surface of the middle of this area.
What I normally do is I suture a homographed homographed vein. So we have a valve bank. So I get a piece of homographed saphenous vein, I suture it to the innominate artery, and then put a biomedical cannula through it. So then the advantage is that no cannula comes in the way. And if you want to perfuse the brain, that is always possible.
Yeah, that's, if you want to do cerebral perfusion, that's a good way. And even you don't need to do that. You just extend your cannula through the innominate and put a snare around it and the perfuse. But for me, it's complicated antegrade cerebral perfusion, and as long as you stay like less than 20-25 minutes.
Yeah.
It's
I also
completely
do it
safe.
on suck arrest. I also do use suck arrest, but the only idea is to remove the cannula. So the homographed vein is very good. The needle holes don't bleed, and we publish it also. The second thing which I wanted to ask you was, like I saw that you were doing the end-to-end anastomosis of the descending aorta with the arch.
Yeah.
So the Texas group has reported the arch advancement, in which they ligate the distal portion of the arch, and then they get the aorta to the undersurface of the arch.
Yes.
And if you see the Jonas textbook, and which your diagram also showed, the anastomosis of the distal aorta goes almost up to the left common carotid artery, because that way they're able to get more length of the aorta. So that is also one of the tricks of doing it. And it's a difficult operation.
Yeah.
It's a very difficult operation. Thank you.
Thank you. I think this concludes this morning's session. Dr. Sakamoto is not here. Thank you for joining.
If you want, I can do like an AV canal.
What?
I couldn't do it.
That's perfectly fine, yeah. See.
So many times. It happens regularly. It's a regular feature with me now. My wife keeps on checking all the time.
Yeah, I'm sorry. I supposed to present the AV septal defect in the posterior course, but I was in a council meeting. I couldn't do it. So the surgery for AV valve, very skip. Everyone knows that's a short. The surgical repair is a single patch repair, double patch, or the modified single patch. This is the surgical technique: single, two, double, and modified single. And these, when you show, you know, the result of single patch technique, 119 patients, and then the 3 operative day reoperation, 8 due to the left AV varicalization, 1 LV outward tract obstruction, which is a very good result. The same, and the AV septal defect repair with 2 patch technique. This is also the like here, but it's some of the unit with a good hand is a very good result. And a long time before, which was no good. This one is between from 1975 to 2000. So the long time ago, the result was no good, and recently improved. The freedom from the operation is not high. It's even in an AV septal defect, but the intermediate type AV septal defect reoperation is much more. From our Japanese database, many of these partial or intermediate type AV septal defect repair was done in many centers, and the complete AV septal defect now referred to big centers, so that more experienced. With the 2 patch, the last either the rusty type A or type C, and this one is also the very good result. I must show the modified single patch technique that probably the many young people are interested in. The modified single patch technique like this, put a stitch to the ventricular septum, passing the AV valve, then passing the atrial the patch. This is probably the first report from Sydney group, Graham Nunn, did operate the 47 patients since 1995, and mortality 2, and then the median age is 3.4 for months. The at that time, the follow-up was only 1.9 years, but they know the much longer follow-up time, which is not much different. Quite good. Modified single patch, the result is the mitral regurgitation. Most of these patients, they have no AV valve regurgitation or minimum or mild. So the moderate regurgitation was only 6% of the patient. No heart block, and no significant lesion VSD. And also, typically, many surgeons, including me, was worried about the LV outflow tract obstruction. But it's in fact, no. This is the other paper from the Canada. And one of my colleagues, the Ugaki, present a paper from Edmonton. They have 51 patients, and both two patch repair and modified single patch repair. And they concluded the shorter bypass time and the shorter cross-clamp time and modified one patch. Of course, the surgery is more simple because only one patch. And the result is not much different. So their conclusion is post-operative LV outflow tract diameter and the LV area VV leaflet coaptation lengths were not significantly different between both techniques. So that the LV outflow tract obstruction is not the issue. Either you do a modified one patch or two patch. This one is the data of the STS congenital database. Nearly 2,400 patients, 78% downs, median age of surgery 4.6 months, and the weight is 5. And the major complication almost 10%, including a pacemaker, permanent pacemaker, and 2.7%. So the overall hospital mortality in the STS database is 3% now. Either you do use the single patch or double two patch or modified one patch. Our experience requirement, I prefer to do. I used to use the two patch because I learned two patch from Roger Mee. And then the modified one patch, my colleague, the Kasahara, he trained in Sydney and the Graham Nunn place, so he preferred to do modified one patch. So he started the modified one patch. Then I also changed my mind. It's more I do modified one patch because the long-term result is very good. And then one of my the big worry was the LV outflow tract obstruction, and that was no issue, even the long-term follow-up. So in the beginning, and many of these patients have two patch, the 110 cases, the hospital mortality 2, and late death 0, and the overall survival is 98%. And then the operation, 9 patients need to reoperate because of the LV left AV valve regurgitation. One patient I couldn't repair, then I did a valve replacement. The operation for LV outflow tract obstruction was 5% of the patient. This is the more until 2014. So this data have more modified single patch technique. So our strategy is if possible, better to do under 3 months of age, especially in a down patient with a pulmonary hypertension. If it's not the Down syndrome, at least until 6 months, we try to repair in a complete type. And the indication of pulmonary banding is the body weight is small, which is quite difficult, especially to the less experienced surgeon, the junior surgeons. It's not easy to do in the small babies. It's much easier when the patient, the body weight becomes 5 or 6 kilos. So that depends on the surgeon's experience, but definitely if the baby is less than 2.5, we prefer to do band. The associated anomalies, the tetralogy or DORB, are more complex patches. It's not easy to do in the small babies, so we prefer to do band, and when the patient becomes bigger, we do a total repair. Either 2-patch or modified single patch is a surgeon's preference. The cleft closure, we usually close the cleft, but some of the patients, we couldn't close the cleft completely because the mitral valve become stenotic, especially single papillary muscles. So these one, the age, the average 6 months, and the median body weight 5.5. The patient had less than 3 months, mostly the Down syndrome. The banding was done, and before complete repair is 16% of the patient, and the 3 patients had a coax repair in the band. Including the heterotaxy in 6 patients. The morphology, most of the patients have lateral type A, and the 70% and the 30% of the type C. The majority of the type C is a Down syndrome. And 2 patients have a double orifice, the left AV valve. The 5 patients have a single papillary muscle, and 6 had a dysplastic leaflet, and 3 are small or deficient left lateral leaflet. Some of these patients, we couldn't close the cleft completely, so we partially closed the cleft. Many of these patients need reoperation, but at that time, the left AV valve grows bigger. We could successfully close the cleft completely. So the 2-patch is just over 50%, and the modified 1-patch, mostly my colleague Kasahara started doing at the 34% of the patient. So in the beginning, mostly like a 2-patch, intermediate type is just closed with the directly, and then the patching to the atrial receptor defect. Since the Kasar was back from Australia, he started modified single patch. So single patch become bigger and more, and the 2-patch, still we have a 2-patch, especially I prefer to do 2-patch in lateral type C. And then he also, also did the modified single patch, 2-patch in lateral type C. But now he is some of the patient with even lateral type C, he do modified single patch. So this diagram, I show you the video. So this patient is down, and the last type A, 3 months, 4 kilos. The waist depth is 11 millimeters. You see the check, and then put a stitch to the superior of the AV valve annulus and the inferior side. Just taking care not create complete heart block. and the testing. Most important, operation point is to find out where is the center of the inferior leaflet and the superior leaflet. So we put the projected mattress sutures in the superior inferior part, and then the marking where we put the suture to the AV valve. Once you find the place we put the sutures to the AV valve, put project the mattress sutures from to VSD in the passing the AV valve. The same in an inferior leaflet. This is especially useful to me, especially useful to, this is not type C, type A, maybe. And then passing the orthogonal pericardial patch to the atrial septum with reinforced with either the small dacron or the PTFE strips, and then close the cleft. This is a post-operative and echo. So the median follow-up on 4 years, the early mortality 1, the hospital mortality 2, and the late mortality 0. So the overall survival is the same in 98%. The AV valve regurgitation, most of the AV regurgitation are less than mild, and the reoperation for the AV outflow tract obstruction was 5. That's the same as before. So since 2010, no left AV valve LV outflow tract obstruction. The actual survival the same. The freedom from reoperation is the 9 out of 10 is the left AV valve dysfunction. So these reoperation due to the left AV valve regurgitation is either a single papillary muscle or the dysplastic or the hypoplastic mural leaflet. These one. If the patient have a usual an AV septal defect, there's almost no reoperation. And either you do use the 2-patch or modify single patch. And also the LV outflow tract obstruction. Unfortunately, all the patient is from the 2-patch repair, and the modified single patch repair is no LV outflow tract obstruction. So these results suggest that the complete AV septal defect repair has a mid-term or the long-term good result. And either you use the 2-patch or modify single patch. It's a preference. But to me, to the young people, it's much easier to do a modified single patch, especially the type A. Type C is quite a deep one. It's not easy, but type A is very easy to do, and the cross-clamp time is much shorter. And the long-term result is the same. And dysplastic leaflet, small or deficient lateral leaflet, and unbalanced AV septal defect, it could be a significant risk factor for post-operative left AV valve failure. Because of most of these patients, we couldn't close the cleft completely. We could either close no close or either close partially. These one have a reoperation, but we know that these patients need a reoperation. But it's better than the Fontan. Thank you. Oh, that's the one.
Thank you, Sanjay. I just have a comment. I do almost completely modified single patch over the last 15 years now, and it's close to 150 cases. No cases of LVOT obstruction.
Yeah.
Very small number of left AV valve regurgitation. However, I noticed that, especially on the right-sided AV valve, when I do this modified single patch, I do more stitches on the right-sided AV valve instead of left-sided AV valve, and most of the time that right valve is overlooked but my feeling, now we are working on that, my feeling that right-sided AV valve competence is kind of issue with this repair, and you do place more sutures, stitches, and then even you go with at the long term, you don't have that patient's back because, right-sided AV regurgitation, moderate cardio, most of the time asymptomatic. What is your experience with the right-sided AV valve on this single patch repairs? Do you feel the same thing, or?
We tested the left AV valve and also the right AV valve too. So quite often put like 1 or 2 stitches to the like a crest part. So we have no reoperation or no severe or more than moderate to severe right-sided AV valve regurgitation. But I know that the one surgeon in Melbourne, you know the name, but not Roger me. He did repair the AV septal defect with 2-patch repair, but he didn't worry about the right side AV valve at all, and no worry. Patient do not die. It only die because of the left AV valve, but then long term they had a lots of reoperation because of the right side tricuspid regurgitation.
Yeah, I agree with you there that we tend to underrate the right side AV valve regurg, and especially it gives you a lot of trouble post-op if you have pulmonary hypertension. So then you have significant TR and they have big levers and all that. I have almost switched to the modified single patch for the last 12 or 13 years, but I find it that it's very easy to teach the residents and all that. But the problem which I have had is to apply this in patients with tetralogy of Fallot or DORB. If you read Dr. Nunn's experience or speak to him, he always uses this technique even in patients with tetralogy of Fallot and DORB. So what is your experience?
Tetralogy of Fallot and DORB, I never did like a modified single patch. I usually do like a Pantone type.
The comma-shaped patch.
Yeah. The number of my experience of the AV septal defect and tetralogy of Fallot DRV is maybe around 9 or 8.
Okay.
Yeah, not huge, but it's almost all the patients with like a comma type patch.
I use a small. Recently, I started using a very small patch on that superior part, not a large one,
So
partial.
just to make sure that the LVOT is not affected. Yeah, because Dr. Nunn has said that he still does the same. The other question which I have for you is, What do you do to the coronary sinus? You take it to the left or you keep it to the right?
In the beginning, I used to do to leave the coronary sinus to the left.
Okay.
And now the more of the patient leave the coronary sinus to the right.
Yeah, because the experience grows.
Yes, yes, that's only the experience. Yeah.
Now, what do you do if you have a bilateral superior vena cava?
Hmm?
If you have a bilateral superior vena cava and the cava
Right.
is coming to the coronary sinus, because that also happens. It comes to the coronary sinus or it comes to the roof of the left atrium. And the cava are both same size. So what do you
Yeah.
do?
I normally do, if the patient have a double left SBC, I cut and then connect to the right SBC, usually. It's not difficult,
Correct
it's
to the
easy.
Correct to the right atrium.
To the left side and SBC, and then
Okay,
connect
so
to the right.
create an innominate vein, that means.
Yes.
You create an innominate vein.
Yes. In a higher position. Normally, if you try to connect below the aortic cannula, it's a little bit like far away.
Yeah.
I normally connect above.
Okay. So I remember having a report from Dr. Cassirida in which he used to connect a Gotex patch between the two cava, and then he had good results. But I have done 3-4 cases in which I've just ligated the LSVC, and it doesn't seem to have any harm on the patient.
And if the after clamping the left SVC, and then the SVC pressure is like at the 50 or less than 20, it might be no difference.
No, because in small babies like 3 kilos or so, it is very difficult to root the cava from inside the atrium. So I think your suggestion makes a lot of sense. Create an artificial innominate vein, because it is hell to do it from the inside the atrium.
Thank you very much. I think we have presidential address starting soon, and thanks for joining this morning. And I appreciate Sunja's willingness to add another excellent video. Thank you.
Have a nice day. This bag is yours? Yeah. There are so many problems we can keep on discussing. So many problems with every operation. Go on discussing, no end. Yeah, Lehman, 1, 2, 3.